All right. Well, for the sake of time, we're gonna get started. It's a short webinar, but we do have a few guest speakers, and then the content that I'm presenting. So we have quite a lot jam-packed in this 1 hour, but very excited that you all are able to join us. Thanks for logging on, and also thanks for your flexibility. We did have to reschedule this webinar for 2 weeks after the original start date. Right, so this is the Strengthening Outreach and Engagement with Underserved Population through CABS webinar. I put this webinar together with my colleague Christina Santana. She is on the chat. She is in the room. She'll be helping out with the chat. She'll be helping out, allowing folks to enter the webinar. Any questions at any point, feel free to unmute, type in the chat, and then Christina will assist with that as well. Right. So funding for this webinar was made possible by the PS 1906 Component A Cooperative Agreement from the CDC. The views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect the official views and policies of the CDC, nor does mention of trade names, commercial practices, or organizations imply endorsement by the US government. All right. So let's get started. So here's what's gonna happen today in this 1 hour that we'll be together. I'll just give you a quick rundown on who we are at NASTAD. We'll go through some objectives. I'll provide you all with an overview and considerations for CABS. And then we'll move on to the highlight of today's session, where you'll get to hear from two wonderful guest speakers. These are folks that have a lot of CAB and community experience, and they're very excited to share more about how they use their CABs to strengthen outreach and engagement with underserved populations. Then we'll leave some space towards the end for some Q&A, and then we'll close it out. Right, so who are we? Most of you are familiar with NASTAD. Many of you, I've seen some names, some familiar names that you've joined some of our sessions before. We provided some TA. But for those of you who are not aware of who we are, NASTAD is a public health, nonpartisan, nonprofit organization that represents public health officials who administer HIV and hepatitis programs in the US and around the world. Our physical office is in DC, but our staff is scattered throughout the entire US. And basically, we provide folks like you who are from jurisdictions and community-based organizations. We provide you all with trainings and resources for a myriad of topics related to hepatitis, HIV prevention and care, healthcare access, harm reduction, drug user health, health systems, policy, and a few other topics as well. Here are some objectives. We want to increase your knowledge and enhance strategies to strengthen outreach and engagement with underserved populations through CABs. Explain 2 to 3 benefits and opportunities of having a prevention CAB, identify 2 to 3 important considerations and best practices for developing and implementing a successful CAB, and strategize at least one next step for developing your own CAB. So a community advisory board. What is a community advisory board? The official definition, well, one of the many definitions is a community advisory board, also known as CABS, which it's the way I'll refer to it moving forward. They serve as a voice for the community and local study participants. CABS provide input into study design and local study procedures. CABS work to ensure that research strategies acknowledge and respect the values and cultural/ethnic differences amongst participants. So basically, it's a meeting between the organization and the community to get valuable input on a specific topic. So what are some CAB benefits? CABs provide opportunities for meaningful community engagement. They help identify and bring attention to issues and concerns in the community. They maximize program and service outcomes, and they lead as a collective. So it is not one individual making decisions and giving suggestions. It is a collaboration between the organization and community members. So let's look at some things to consider when developing your CAB. You want everyone involved to have a clear understanding of what their expectations and limitations will be. This includes things like time constraints, what does the budget allow, and what resources are readily available or will need to be available in the future. You also want to be clear on the things that are not up for discussion. For example, this can include legislative framework, decisions that were already made and are non-negotiable. We work in a field that houses confidential information, and certain things cannot be shared with everyone, not just for legal purposes, but also out of respect for your clients and patients. So we want to honor that as well. And then of course, some expectations and limitations may be challenged when presented, so you should be prepared to de-escalate and reroute any potential pushback and explain why those decisions were placed. One way to reinforce and remind folks of those expectations and limitations is by creating a community agreement. And stating it at the beginning of every meeting is extremely helpful. Community agreements are essentially like ground rules that we establish early on to set expectations for how we want to communicate with each other. This agreement is created with the community and everyone gives their own input. So again, it's not just the facilitator putting a list of agreements, it's the community as well. This agreement is created with the community and everyone gives their input. These agreements help set both practical norms and broader intentions of how we want to approach the conversation. So an example would be you present the community agreement to folks and you say, in this space, we agree to, and then on your screen, you can see some examples. So we agree to manage our technology so that folks are not on their phone or laptops consistently. We agree to use I statements so you're not making assumptions and generalizing on other folks in the room. We agree to ask clarifying questions. We agree to be comfortable in silence. We agree to make space, take space, etc. You want to consider what topics you want to discuss. So this can include marketing materials, testing locations, event ideas such as logistics, incentives, knowledge of existing community special events. You also want to consider the program implementation and development. You want to brainstorm through some ideas with the community members and how that project is going to be promoted. So who should be a part of a CAB? This varies from organization to organization, and it also depends on the type of CAB. But some considerations for folks that would benefit your CAB are individuals representative of your program's priority population. And in the next slide, I'll go into more specifics as to why representation matters. You also want individuals who are utilizing your services, and you definitely want to include certain community leaders, and not just those that automatically come to mind in the HIV prevention field. You want to think outside of the box of what other community leaders would be influential in making decisions. So you want to consider the elders, you want to consider nightlife leaders, performers, faith-based leaders, etc. And then, of course, you want to consider individuals impacted by HIV/AIDS. An organization may have multiple CAPs going on, depending on the priority population and focus of the prevention program. Each community has different needs, and dedicating space to discuss the community-specific needs can make a huge impact. So why representation matters? Representation is how the media portrays and shows us things about society. This can include individuals, populations, communities, and in today's society, more and more people are feeling comfortable enough to come out as LGBTQ at younger ages. But we're seeing a growing problem is in that community is that they often tend to be hypersexualized by the media. Because of this, the media continues to treat romantic relationships as synonymous with sexuality and sex, which leads members of society to view these relationships as taboo. Also, many figures and characters in the media that identify as LGBT are white, and this singular portrayal can create negative self-image, reinforce stereotypes and stigmas, and can isolate young people. Representation allows all individuals, especially the youth, to view characters, programs, or images they can relate to. It helps to embrace your identity, your culture. It creates a space for stories that are often missing, and it grounds the reality for many people. Without equal representation, people basically just feel isolated and left in the dark. And this can have negative implications for health outcomes. Another thing to consider is who should facilitate your CAPs. So it's difficult for many organizations to assign a CAB facilitator role as the sole responsibility to a staff member, and this is usually tied into budget constraints. But usually this is an added responsibility to someone's job duties along with their everyday tasks. But CABs require commitment, and it is important that facilitators are giving the time and energy that it requires. Other if they don't, then cabs will be overlooked and not seen as having the same level of urgency as other deliverables. Um, so you want to make sure your cab facilitators are folks that have the capacity to do so, not folks that are overwhelmed with other competing projects and deadlines. Consider how many people your organization can accommodate. So now we're looking at size. Uh, Here are some things to consider when deciding the size of your cap. So are you looking for quality versus quantity? One thing that you'll always consider is the budget. And then some pros and cons into what a smaller cab and a larger cab looks like. So smaller cabs tend to be best when focused on a single issue. They tend to be easier to manage discussions and the meeting logistics, but their low attendance may lead to very small or canceled meetings. On the other side, larger cabs, they tend to be better when you're looking at topics with a broader scope. They allow for a cab with a larger variety of lived experiences and profession fields, and they are easier to maintain active cab meetings. The more people that there are, the less likelihood there will be of a low turnout, and the less likelihood of you having to cancel your cab. So how often should your CAB meet? Basically, this varies depending on what you're tasking CAB participants to review. But ideally, you would find a sweet spot to meet that works for everyone, and you want to be consistent with that sweet spot. And this is not always the case, though. So if you can't, then propose different times throughout different days of the week, including weekends if you can. This because you want to be able to accommodate as many of the members as possible to give everyone an opportunity to attend and provide valuable feedback. So you do want to be as flexible as possible in terms of the frequency of your meeting. And what impact will the programmer plan have on these stakeholders? You want to consider all this when marketing and recruitment. You want to work with facilitators and prospective members on a name for the cab. You could just call it, if your organization is called ABC, then you could call it the cab for ABC or ABC's cab. You could also get very creative with your title. Consider a variety of recruitment strategies such as word of mouth, social media, recommendations from staff and other clients. You can use QR codes, outreach events, flyers. And you always want to be clear in the expectations and the outcomes of your cab when doing the recruitment. Some successful practices for effective cabs. So similar to how many of us are used to doing needs assessment for clients, needs assessment for jurisdiction, CBOs, things like that. You should also consider conducting an interest assessment of your CAB members. So you want to seek information from CAB members on the time and date that works best for them, on topics of interest, on barriers and opportunities for strength, on any transportation limitations that they may have or that they may be aware of. You want to gain input on what they want the goal of the CAP to be. And then, of course, always create that community agreement. It's important that you create that community agreement. That way, everyone is on the same page, and then you maneuver those cabs accordingly. And then, of course, you always want to honor what is being said in the cabs, and what information is being given. Otherwise, then the cab members will feel like they're voicing their concerns, their opinions, their suggestions, but they're not seeing action being taken. The field we work in is ever changing, and similar to how we adjust our work policies and procedures, we also need to make adjustments within our gaps. So if something doesn't work, try a different approach. Be as transparent as possible and explain to the CAB members as to why things are changing. And process evaluation can help strengthen your CAB. This helps assess implementation fidelity, identify barriers and facilitators, enhance program quality, inform decision-making, and guide continuous improvement efforts. So if you already have someone at your organization that conducts program or project evaluation work, consider asking them to conduct the process evaluation for your CAP as well. And just some final reminders and considerations. Here are some ways to enhance the experience that CAB members are having from your meetings. So trust and listen to your community members' expertise. If you can feed them and give them something to drink, do so. Also, if you can pay them, that'd be even better. We want to compensate people for their valuable insight and their time. Valuable participants' time and investment, make sure they know they are appreciated. A way that you can do this is by annually recognizing CAB members' contributions and insights. If you can give them certificates, acknowledgement, gift cards, things like that, will definitely enhance the meeting experience that CAB members have. And you always want to use person-centered language in these meetings. Linguistic prescription to avoid marginalization and dehumanization regarding health issue or disability. That is essentially what person-centered language is. You don't want to describe people by their illness, disability, or their drug use. You want to recognize their complexity and their identities. You want to avoid using group, illness, disability language to describe negative states. Language is powerful and it can build bridges or marginalize. And so by choosing a person-centered language, you'll build stronger ties with your community. And don't assume, remember that you are wanting to strengthen the ties with your underserved populations, and you need to consider how you approach them. So do your research, understand their culture, interest, assets, limitations, etc. Don't simply make assumptions. So some questions that you can ask yourself would be, what do they care most about? What are they most concerned about? Why do they / should they care about your goals? How have you previously engaged this group? What went well? What didn't? How engaged were they? Always be cognizant of what you are asking of them. What barriers might they face with engaging with you? What is the best way to approach and engage them? And lastly, I want to leave you all with just 2 questions to get you thinking about your next steps. The first one is, what do you think you need to start or enhance your CAB? And the other question is, what resources do you need to make that a reality? So these are things to consider moving forward. And hopefully you'll get some more insight from our guest speakers because they have a lot of knowledge on this. So that was the content portion of the webinar. For the sake of time, we are going to move forward and have our next component, which would be our first guest speaker. Their name is Mitchell Capone. As a member of multiple and often other communities, Mitchell knows how important it is that representation matters. Mitchell currently is the Network HIV Director at the Family Health Centers at NYU Langone in New York City. The programs in his department provide comprehensive, equitable, and quality services to communities most in need. A big proponent of examining the social determinants of health and how issues in our communities are also impacted by intersectionality, Mitchell has helped collaborate to create LGBTQ+ and sexual health training modules, published research, presented at conferences, webinars like this, have been appointed to the NYC Mayor's HIV Planning Council, and is a part of many other groups advocating for services. And Mitchell, I believe I saw you in the room.
Yes, I'm here.
Perfect. So I'll unmute and the floor is yours.
Okay, can I share some slides?
Yep, give me 1 second, just gonna give you more access. All right, you should be good now, Mitchell.
Okay, yeah. I was like, you gave me access to share. Now let's see if I actually can figure it out. Okay.
You can see your screen.
Can everyone see my screen? You can? Okay, great. Thank you, Gerald. Like he just said, my name is Mitchell Capone, and I'm the Network HIV Director for the Family Health Centers at NYU Langone, which is complicated, and we will get into that because the FHC, as we call it, is its own separate entity, but it is embedded within the NYU Langone system. We were founded separately many, many years ago, and now NYU Langone is our parent company, which means that we can act independently. We're our own network of FQHCs. Throughout Brooklyn, but we are also linked. We have the same EMR as NYU Langone, which actually helps us in a lot of ways because we know when our patients are in the hospital, and we can also work with people. So that helps us with a lot of our folks, and so we have relationships with the main hospitals here in Brooklyn and Manhattan. So the FHC, like I said, is a large federally qualified health center. The vast majority of our patient population are immigrants, people of color, low income, English as a second language, or Spanish, Creole, French, Russian, monolingual. And we operate throughout Brooklyn. A note in here, because I'm going to share some data, that Brooklyn is the largest borough in New York City. I'm not sure how familiar people are with New York City. It is big and large and complicated, just like our healthcare system. So the Family Health Centers was established in 1967. Like I said, we're affiliated with the NYU Langone Health System. Our locations that primarily serve people in the Sunset Park, Park Slope, and Flatbush neighborhoods of Brooklyn. We've had Ryan White programs since 1990, and we almost have almost 700 HIV positive patients in care, and we serve over 100,000 patients annually. So kind of just going over a little bit of epi data. So if you can see my cursor, I was like, this area is a park, and we operate all around the park, our main health center. So you can see some areas are the darkest orange, and then some areas are a little bit lighter. I was like, and what this is as of 2022, NYC DOHMH HIV diagnosis rates. I was like, so we operate in some of the heaviest areas of diagnosis, as like, and then also some lighter areas. But Sunset Park in general has the second highest rate of chronic Hep B in the city. We also have a huge prevalence of hepatitis C. And then also one of the largest neighborhoods of newly diagnosed HIV positive folks. And Brooklyn has the highest rates of newly diagnosed people in New York State, as well as the highest rate of STIs in New York State. So lots of different things that we assist with, and where you have about 9 health centers that are deeply embedded within these communities because we've been there for, in some of them, over 50 years. I think I just kind of said some of this stuff. So I talked about newly diagnosed cases. I did not update that part. Never mind. But let me talk about our cap. So we have a really robust cab. We say we meet quarterly, but our cab meets all the time because they're a part of different groups and things, but we have specific cab meetings held quarterly. We have about 10 folks in our cab at this time. And some of the things that we do with our cab that are kind of exciting is we give them a lot of leeway. We like for certain projects like Pride and World AIDS Day, specifically for World AIDS Day, we try to make it a celebration for people who are HIV positive, especially our long-term survivors. And we actually give our cab a budget and let them plan what we do for World AIDS Day. And so every year we usually have have the auditorium at the Brooklyn Hospital, and we've had people read poetry, we've had family members sing, we've had dance performances. We also do art project every year that's sort of in relation to the AIDS quilt. I'm sure everyone's familiar with, but we do our own mini version of that where people can make like a patch and decorate it with whatever their intentions are, or someone that they've loved who they've lost, whatever that they see fit with it. So as Gerald was saying about how it's really good to recognize what cabs do, I was like, it's in our way, we've given them the ability to lead an event, and so they get to not only have their voices represented, in other things that we do, which I'll get to, but they actually get to see they get to, invest in something and in a project that we put our name on. So we meet with them to give them oversight, but they are the ones who are really leading those projects as like, and then same thing for Pride. For Brooklyn Pride, it's different than Manhattan Pride. Manhattan Pride is a march, whereas in Brooklyn Pride, it is a march and sort of a street fair. So we allow folks to join us and give out information, talk about their experiences with folks, and really be a part of the day and take some more ownership of, their role in our successes. And that's why my next point, I say it's a bi-directional information sharing, because I don't ever like to think about it as like we have our CAB meetings and we just go and we tell them, okay, this is what we're doing, get on board. I was like, we want to figure out what issues or what things are our CAB members seeing, because there are patients, what are they seeing when they come in for appointments, what sort of things can we work on with them. So we like to share out like statistics and things like that with them that maybe they're not aware of or they don't see at that level, but then at the same time get their feedback on that, because if we're saying we're doing amazing and we have a really low we have great appointment ratios and people are seeing their providers when they want to be seeing them, and then we have our CAB tell us, actually that's not true, I can never get in, it takes me a month to be seen. I was like, we want to take that back to our providers and have those conversations. Luckily, that's not the case. I was like, but that is something that we try to talk to them about to see what issues are important to them, as well as what issues are important to us to let them know about. So we like to have at least probably at every one of our quarterly meetings, we talk about data to them, both prevention and treatment related data, and then getting their feedback and bringing that to leadership, like our chief medical officer or our HIV medical director, as well as just all of the other program supervisors within my department, to let them know how are we doing. And it's sort of like a report card for us to see how we're doing and if we're addressing the things that they need to be, that they're seeing as needs from their end. We also work with priority setting and projects. So one of the things that we noticed from our end is that the older adults were not getting screened for like a sexual health screener or doing risk assessments. So we went to our CAB, which has some folks who are older adults living with HIV, and we sort of brought this up to the group and we said, what can we do about this specific thing? And everyone in there said, this shouldn't be limited to older adults. We want to see this for everyone. Is there something that can be done that focuses on all of us versus just singling out certain demographics? And we were like, yeah, that is a smart thing, because then that reduces stigma if everyone's being asked about it. So we were actually able to, from that CAB meeting, to go and develop what we call our sexual wellness screening tool, which is now at initial patient appointments and at annual patient appointments. Patients ahead of their those appointments go and fill out this screening tool that talks about, the types of sex that they're having, sexual partners, certain risk factors and things like that. And that helps us gather data about who our patients are and risk that patients have, but also then lets patients know that we are interested in these conversations. And so they can direct those appointments when they're meeting with their providers. And that's beneficial, because that also then means that we can order some sort of testing, because we know that sometimes providers also aren't, if they see that you are married or if you're of a certain age, they may not screen you for STIs or something like that. But we all know that you don't stop having sex at any specific age. So now we're able to utilize this tool to not only get better data on patients, but also be able to drive better conversations from the provider side and the patient side around sex, and now everyone's being included in those conversations. And so that's one of the projects that we've done in the past year that we involved our community advisory board on. Yeah. And I think that we have questions at the end. And I know that Tyler is our next speaker. I don't know if you want me to give it back to you, Gerald, and then you can give it over to Tyler.
Yeah, perfect. Thanks, Mitchell. Yeah, it was great to hear your examples. It's nice and reassuring to hear when caps are working. So up next, we have Tyler. And at the end of this, yes, we'll open it up to some questions. Some folks have already put some things in the chat, and I'm sure they'd love to hear your thoughts, Tyler and Mitchell, on how they can navigate through that. All right, so up next we have Tyler. Tyler is a member of the California Department of Public Health HIV CDR Community Advisory Board on behalf of LA County. He is involved in healthcare policy and advocacy in West LA, where he has collaborated on projects ranging from PrEP distribution policy to expanding access to psychological services with the UCLA Health and the UCLA ASH Center. And as of recently, Tyler is currently a medical student at the Kaiser Permanente School of Medicine. Tyler, thank you for joining us, and the floor is yours.
Yes, thank you so much for that introduction. Let me see if I can share my screen here. Okay. Sorry, 1 second, I have to give Zoom permission to share. Okay, perfect. Can you all see the presentation?
Yeah, we can see it.
All right, thank you so much. So again, thank you for the great introduction, Gerald. So my name is Tyler. I'm a member of the NASTAD CDC HIV CDR Community Partners Panel, and originally I was a member of the California DPH HIV CDR Community Advisory Board. So as you can see, my positions involve quite a few acronyms, and they can be quite confusing. But the main point I want to make to you guys here today is that I've really loved being a member of the California HIV CDR CAB. It's been a very valuable experience for me, and it's something that I'd love to see happen in more jurisdictions because I think it's a wonderful opportunity for people to, as Mitchell said, really try to take charge and get involved in their own care and in their own advocacy. So my personal involvement with the CAB, which I've been a member of for the past 2 years, began when applications for the first cohort were disseminated in August 2022 through community partners, BPH communications, and social media. And so that's why I found the application and ended up applying for a position on the first cohort. So kind of in contrast to Mitchell, coming into the CAB, I really did not know very much about CDR or the more advanced nature of HIV public health policy. I applied while I was a UCLA undergraduate student involved in on-campus and Los Angeles community-based organizing, especially for sexual and gender health, including transgender advocacy and HIV advocacy, as well as being in substance use counseling. So I definitely had some on-the-ground experience, but coming in, I was absolutely ignorant to the finer workings of HIV CDR. And for that reason, I found the board to be especially helpful in helping me educate myself and others around me in what CDR is and why it's so important. And that's one of the big things that I think is a huge takeaway for the importance of CABs. So throughout our first meetings, we learned about the basics of CDR, the current status of the HIV epidemic in California, discuss elements of confidentiality and stigma, and mental health departments from Los Angeles and San Francisco. So that's how I really got my background in CDR and began to understand more of why it's important and why I wanted to help advocate for it alongside health departments and other leaders in the field. So in 2023, because of my position on the CAB, I was able to apply to become a member of the NASTAD CDC National Community Partners Panel, which is actually where I met Gerald and Mitchell. And so through those, I've had many amazing opportunities that I'm so grateful for, including being able to attend the 2023 and 2024 National CDR Summits, where I got to meet many amazing doctors and researchers and health department workers from the CDC and jurisdictions all across the country, and got to represent my jurisdiction through various talks and opportunities that I would never have had otherwise. So I'm very grateful to my original CAB at California and LA for making all of that possible. Okay. So now I want to go ahead and talk about some aspects of how our CAB functions and how we were introduced to these various aspects of CDR from the perspective of someone who, again, was essentially a complete novice to the field. So as part of our onboarding, we were introduced to various aspects of CDR throughout the first year of CAB meetings. And I think in this case, if you're planning to create a CAB for your own, one of the really important things is to set member expectations and goals. So for me, at least, this is my first time being on a CAB, and I really wasn't sure what to expect in terms of workload, compensation, goals, etc. And I think that's especially true for people who may not have as much political organizing experience or government experience, which is which should be a major part of your constituency. And so setting those goals, making them clear what you want them to do and why you think they're important to have is something that I think is very valuable when you're first onboarding your CAB members. We then jumped into guided discussion of prioritization of topics, which is really helpful because it allowed our CAB organizers at the health department to see what we wanted to talk about and what we brought to the table in terms of experience, knowledge, and interest. And so I know from talking to them that they really use that information to guide the topics we've had to discuss at our various quarterly and ad hoc meetings. And so understanding who your members are, why they're there, and what they bring is a very important part of establishing a CAB. So as for format, we have quarterly required meetings with additional ad hoc meetings as deemed necessary by the organizers. And those ad hoc meetings are mostly optional, but we do try to attend all of them. And at those, we discuss various topics outside of the established curriculum, you could say, that come out throughout the year as they try and address various outbreaks and issues they're seeing on the ground. Currently, we have 8 members, including people living with HIV, medical practitioners, community organization members, and even some university professors, which I think is really cool. One of the things that I think is so great about the CAB is that we're able to draw on such a diverse variety of perspectives that we wouldn't have otherwise. And each of us comes with a different knowledge base and understanding of these issues, some from personal lived experience, some from academic experience, and some from professional experience that really helps us to get a broad overview of the issues during our discussion. So that's one thing I also prioritize in creating a CAB. So now I'd like to talk about what the introduction and onboarding of the CDR was like, because again, for myself, I knew very little about the fine nature of CDR coming into this. And I think that's true of so many people who are either living with HIV or at risk for HIV. And making sure to inform them so they can inform them both themselves and those around them in their community is so crucial, in my opinion, to reducing the stigma and misinformation that comes with HIV and the establishment of CDR in these various communities. So our introductory meetings were targeted towards all knowledge levels from professional to complete amateur, and they were informed really by member surveys. So during those first few meetings, they were really asking us and digging deep. What do you know about CDR? What do you want to know? What do you think are some key vulnerabilities or problems that you would like to see addressed or explained? What's your interest in being here and what calls you here? What do you think people in your community would want to know about CDR? So by understanding all those things, I think our CDR organizers, our CAB organizers, were really able to develop a curriculum or lessons of sort that targeted what we wanted to know and addressed our concerns or fears. So first we had a summary of the CDR programs in Los Angeles, San Francisco, and California as a whole. And that was really helpful for me because it allowed me to really get an overview of what this looks like at a community level, both in my jurisdiction and in other jurisdictions, and see how historically the health departments have tried to address that. Next, we have an introduction to what CDR itself is, so cluster detection and surveillance, including molecular HIV surveillance, time-space surveillance, and partner services. I think these are topics that are really worth digging deep on to inform your members about because they often cause so much suspicion and stigma and misinformation when we're trying to advocate for CDR to our communities. People are really suspicious of words like molecular surveillance or time-space surveillance, and making sure that at the very least your community partners understand what those words mean and why they are not dangerous or why they're not stigmatizing or shouldn't be at least can really help get that information out to the community and make sure people don't necessarily flinch away as much when they see these things being discussed. Remember too that your CD members are not intended to just keep this to themselves. They should be people who can hopefully advocate for this to the rest of their communities and be bridges between your health department or your jurisdiction and your constituents you serve. And I'm thinking for myself personally, being able to know more about what surveillance means, has allowed me to inform many people in my life and encourage them to seek testing or sexual care they would not receive otherwise, but they would not give otherwise. We also learned a bit about what member level, cluster level, and programmatic response means. And this was great for me because obviously being new to CDR, I had never seen a cluster level response, at least not knowing what it was. And so seeing all these different aspects of what health departments are trying to tackle when they see an HIV outbreak helped me as a community member and partner really empathize with what health departments are going through and why they need to ask for this kind of information or this kind of surveillance from our communities. And again, I've explained that to many people over the past 2 years who would not have sought care otherwise. Next, we came to member-led topic/input, and this was the real meat of the CAB, I would say, for the past 2 years. Again, this was all based on what we expressed interest in and what the CAB organizers recognized as active issues or topics that they wanted to see us contribute to. So one example would be our discussion of data privacy, presentation, and discussion. So as we know, privacy, surveillance, and respect and transparency are huge issues in CDR, and communities like the LGBT community, the community of drug users, all of them are really worried about these things and interacting with health departments. And so we had entire meetings dedicated just to asking us, what would members like to see in terms of privacy and surveillance? How can we convey respect and transparency through our communication and marketing? And the members all had really great responses that addressed so many facets of the issue. Again, we're talking to people like university professors on one hand, and also people living on the ground with HIV on the other hand. And so you really get a wide variety of things to consider from that. I learned a lot, and I think our health department learned a lot just from watching our discussion. We also discussed stigma and misinformation. So how to combat stigma and how can health departments best use language to avoid perpetuating stigma. So I remember in particular that we had a long discussion about the nature of the word cluster itself, and that was really informative to me. I still can't give a single solid answer, but I can tell you that we discussed various aspects like how cluster can be a stigmatizing word you may want to avoid when communicating with your jurisdiction. But at the same time, if you actually call people clusters in your internal communications and then refuse to call them that when you talk to them face to face, that can also be a source of suspicion because you are not being honest with them about what you call them behind their backs to be transparent. And so that's not one, there's no one single solution to that. I think that's something that you have to discuss yourself with your community and come to a conclusion through CABs just like this. Lastly, another meeting I really enjoyed was when we had a town hall meeting with members asked to invite partners from the community and organizations. And so we were each asked to invite 3 people that we knew from either our local communities or the organizations we worked with to attend this town hall on CDR. And that town hall consisted of material that was brought in for a wider audience, including, again, people who do not know about CDR. And I keep coming back to that point because I think it's so important. CDR is really confusing for people who don't understand it. And being able to create these contact points in the community who understand the basics of CDR and can tell others why it's important and why it's not as dangerous as some may think is such a huge stepping point, I think, to creating trust and transparency with our communities and helping people feel confident in navigating the world of sexual health care and HIV surveillance. And that's really important when we rely so much on partner surveillance and that kind of very personal information. So I have here a sample of some discussion questions that we've used in the past for our CAB. And so obviously you may want to develop this based on what your concerns in particular are. But as you can see, they're really tailored towards what people are experiencing and feeling from their lived experience. So it really asks us, what comes to mind when you see these words that we use? How do you think we can introduce and communicate this information? How do you think we can navigate those who just don't want to hear the basics and those who want to actually know more? And I think all of these were great examples of questions that really facilitated a rich discussion amongst all of us. I mean, we discussed these questions for more than 2 hours. And so when you, as people who may organize the CAB, are trying to come up with discussion topics, I encourage you to really think about what is relevant to the people that you work with and what is relevant to the people who you have selected to be at your CAB. And those things are also very intimately tied. In terms of the CAB, you really want it to represent various facets of the community and those who work on it. And so, for example, I will say that I myself don't live with HIV. And so while I think my perspective is certainly still valuable, I wouldn't want it to be held above or with those who actually live with HIV. And I wouldn't want people like me to be the sole members of a body of a CAB. The problem with that is that can be kind of difficult because when you send out applications for a CAB, I think those who are most likely to see it are those who need less intervention. So, for example, people like me or people like professors or health department workers who are already in a place of somewhat positional privilege. You know, we have computers, we have resources, we have time to contribute to these CABs, which people who are actually needing the help, such as those who may be using drugs, those who may be homeless, or those living with untreated HIV, may be less likely to join because they don't have the time, they don't have the money they don't have the money to lose, or they just don't have the methods of communication to reach this. Or lastly, they just may not trust the department enough to want to contribute their time. They may not feel valued or appreciated, and that's a huge issue. And so I think it's really important when you design your CAB to consider how you can market it to reach those who are truly going to give you the best feedback on how your interventions are working. For that, my honest opinion is that you really need compensation or incentive to reach those people. And I know that can be hard because we are all struggling to get funding. It is not an easy thing to just produce money and give it out. But I really encourage you to look for it if you can, because that is really the only way you can get people to come who are not already living with the benefits of institutional privilege. Like they're the ones who need that money and incentive. You can also consider which avenues are most likely to reach your target audience. For example, I work closely now with an FQHC on Skid Row that has a huge homeless population in Los Angeles, and many of them don't have permanent addresses or phones. If you advertise solely on social media or through virtual applications, there is simply no way for them to get that communication. So how will they ever join and make their perspective known? So one solution that we've explored is to use local FQHCs as mailing addresses. So many people at my FQHC use the doctor's office as their mailing address, and the office collects their mail and saves it for them and gives it to them whenever they stop by. And so creative solutions like that can help you to really reach people who may not otherwise have easy access to these opportunities. And I think that's very important when you're trying to create a CAB that is truly informed by the opinions of those who have not been seen beforehand. You can also consider target demographics. So one example would be many times I've seen advertisements on, for example, Grindr in order to reach the LGBT community. And I think all of those are really creative options and avenues to explore as you consider how you really are going to get the people to actually contribute the most valuable perspective to join the CAB and stay on as longitudinal members. The last thing I'll say too is that one thing I really, really appreciated from my time with CAB was just how many opportunities I got as a member who again came in with nothing really, with no knowledge or connections in this community, to come in and attend events and network with health departments and associated bodies like the CDC or the NIH and join other advisory panels or groups. I really enjoyed having the chance to share my perspective beyond my CAB through opportunities like NASTAD and the CDC Community Partners Panel, where again, I attended the national ILCs and had such amazing experiences, met so many people and learned from them and shared my own experience with them. And I think that's a very important part of how you can empower these people who are on your CAB who may not have grown up with traditional education or traditional experiences of power that have given them a voice. Many times you want their reach to expand beyond just your jurisdiction so they can share it with anyone who can benefit from that. And if they feel empowered to share their stories, they will also feel empowered to take charge of their own care and advocate for both themselves and their communities. So I really think it's important that when you consider what you can also do for your members of the CAB to empower them and make sure they are being heard beyond the scope of your CAB. For me, this has led to so many opportunities I could have never had otherwise, and I just think it's such an important part of the CAB for me, and one thing that I'll always be grateful for to people, to the folks at the California DPH for allowing me to do and helping me to do. From a presentation.
Thank you so much, Tyler. Yeah, it was great to hear your perspective as a member and also Mitchell's perspective through like the organizational side of it, um, the admin side. So we do have 6 minutes left, but we definitely want to open it up to some questions. So folks who are joining us, feel free to type your questions in the chat or unmute. But I do want to address first some questions that were mentioned earlier, and it was about incentivizing folks because we are aware of how valuable their input is and their uh, their time should be considered and incentivized somehow. And so folks were asking how can they provide the members with food, drinks, or even some sort of gift card when the funds that are tied to their cap implementation limit uh, the compensation aspect from it. So Mitch, I don't know if you can talk if you have you guys been able and or successful in finding funding that where you can provide that sort of resource to the members and Tyler, for you, have you received some sort of compensation or even if it's food, drinks in the cab that you're a member of?
Yeah, I will say that we have not received compensation, and that doesn't bother me personally because I'm lucky enough to have stable housing, food, etc., and other opportunities. But that's why I really made a point of if you can't offer compensation, you are not going to reach the people who need the help the most because those are the people who are most likely to benefit from and need compensation to be able to afford this opportunity.
I completely agree with you, Tyler. So luckily, we are able to provide things like Metro cards and food through Ryan White funding that we have. Because we know that for some of our members, I was like that they experience food insecurities as well as transportation issues. So we're able to utilize some of our Ryan White funding for that. I was like, but we aren't able, I have not figured out a good way to give people gift cards or something like that. It's like, and we would love to. I think that there was a discourse going on in the chat where there were some people saying that they, if you have this level of funding through CDC or something, you're not able to do this or that. And I agree with that. And I wish that, and this is something that I think I advocate for, is that whenever we talk to our funders or have those conversations, they always want to hear what is a cab up to, how are you having meaningful engagement with your community. So keep pressuring and talking to them about how we might be able to offer, fair compensation for people's times or something like that, as like so that one day we might be able to. I was like, because I think that is really important.
Thank you. Yeah, and someone in the chat, so Dr. Jermaine Brown, if you are on, if you feel comfortable unmuting, feel free. But Dr. Jermaine Brown suggested partnering up with a vendor and having that vendor facilitate one of the CAB meetings. And so naturally that vendor would provide the service that whatever food item or drink that their business offers. And that is similar to what I mentioned in the slides. A way to engage your CAB members is eventually having them participate. So it's great that Dr. Jermaine Brown mentioned that. If you want to elaborate on that, Dr. Brown, feel free, unmute. If not, you could type something in the chat. All good, no pressure.
There's a question in there for me from Dean asking if so my cab is largely related to HIV treatment and prevention, and there is a larger cab for the FHC in general made up of people from the community, but I am less involved in that one versus this is the one that I interact with and oversee.
Yes, thank you, Christina. So the concerns and suggestions that you all have mentioned, we will take it back to our team and our partners, and then hopefully we can provide you all with some further guidance and resources on this. Thanks, Christina. All right. So we got about a few seconds left. I want to honor everyone's time today. We will be sharing out these slides after the webinar. We will have my email, Christina's email, Tyler's contact information as well, and Mitchell's. So we'll send that out to everyone. Tyler, I see you unmuted. Did you want to say something or you're good?
Oh, no, sorry.
Oh, no, you're
Thank you.
fine. All right.
I'm happy to answer any questions.
Oh, good. So we appreciate you all for joining. We are at 4 o'clock now, so I hope you all have a great rest of the day, evening, depending on the time zone you're on. It's been a pleasure, and we look forward to helping you all with another topic in the future. Thank you all.
Thank you.
Bye-bye.